Hello, this video is dedicated to the very important topic of mental health, mental illness, and other related behaviors. When we talk about mental illness, we are facing an especially challenging conceptually issue. Compared to physical illness, such as some trauma, where we can see an injury and observe the damage directly, when we talk about mental illness, we're talking about something that we cannot observe directly. Even if we believe that the mental is nothing over and above the bodily, if we believe that the mind is just a function of the brain, we still don't have a way to directly observe what goes on in our heads. So when we talk about mental health and mental illness, what we can actually observe are the behaviors. So we assume that voluntary behaviors have some sort of mental cause. We decide to do something, we want to do something, we're thirsty, we want to drink, so we go and get a glass of water. So the behavior corresponds to our mental state. When we talk about healthy behaviors, we usually talk about healthy lifestyle, a person who can maintain healthy relationships, a person with generally positive attitude, somebody who's generally happy. So people who look happy, who feel happy, who are very successful, are considered to be healthy people. In contrast, mental illness would be associated with some sort of dysfunction in those areas of healthy behavior. So somebody is, let's say, abusing substances, somebody has an eating problem. All of these issues are going to be attributable to some sort of psychological causes. And when there is an excess of that kind of behavior, we are going to consider somebody as having some sort of psychological dysfunction. So this is by and large how we think of mental illness in the contemporary medical model. That hasn't always been the case, and also it's not a model that is accepted universally. There are people who simply deny the reality of mental illness. Many people think that that is just a social contract. It is invented in order to control people's behavior, and there isn't any sort of biological aspect to it. But from a medical point of view, we do talk about illness, and we're going to look at the ways that's conceptualized a little later on. We're going to go over these alternative interpretations of what we call deviant behavior. When we talk about deviant behavior, we talk about something which deviates from the norm. So if we consider the healthy behavior to be normal behavior, there will be deviant behavior that is not what we generally expect a healthy person to do. So to some, that is going to be just a choice that people make. It doesn't necessarily mean that there's some sort of cause that the person doesn't control. So under this interpretation, all kinds of behaviors are going to be attributed to the person's free will. The person decides to do these things. So if the person's not acting normal, that's because they want to be in some way different. Now, others would also say, well, even if these behaviors are deviant and they're considered not to be normal, do they necessarily count as unhealthy behaviors? Say somebody abuses some stimulant, let's say caffeine, or even something more serious, like say Adderall. If that person becomes more active or more creative than the normal, would we consider that to be unhealthy? So that's a question that needs to be addressed before we can conceptualize mental illness as any deviant behavior. So with these opening questions, we are going to go briefly over some historical examples of how deviant behavior was conceptualized outside of the medical model on deviant behavior. And we're going to look at an example from the Christian tradition. There are other possible interpretations that are still based on a religious worldview, but we're only going to look at just a small number of Christian practices just to make the point of distinction between the traditional religious beliefs in Western culture and the mainstream Western medicine. So there are two ways to conceptualize deviant behaviors from the point of view of Christianity. On one hand, you could have demonic possession. That would be a situation in which we have an individual to whom some misfortune happened. It wasn't the person's choice to exhibit the behaviors they exhibit. They have been possessed and somebody else causes these behaviors. On the other hand, we have the notion of sinfulness. This is when a person is identified as choosing the morally deviant behaviors that they're exhibiting. And within the context of Christianity, here again, the person is going to somehow be associated with the devil, with demons. But while in the first case of demonic possession, the person is not freely choosing to be partner with the demons. In the second case of when we consider somebody to be sinful, the person is actively choosing to associate with the demons or in some way is responsible for what they're doing. And this would be an offense. And as such, that's going to be a subject of punishment. So the person knew what they were supposed to do. They knew what they were not supposed to do. Their deviant ways were choices they made to do things that are forbidden. So now they have to be punished for that. So in secular cultures, we still have multiple ways to conceptualize deviant behaviors, and they're not necessarily going to consider them pathological. Some deviance in behavior would be praised, actually, would be considered as some unique personality. So not everybody could just walk around and start a conversation with anybody, be very charming, be very charismatic. That's not going to be a normal behavior. Not everybody can do it, so that's not going to be the average. So in that sense, we have some deviation from the norm, but here, that deviation is considered something positive. Then on the flip side, we have that deviation from behavior that makes people unlikable. So this is where we talk about weird people that are not quite like everybody else. There's something about them that makes us feel uncomfortable. There's also the concept that some people are just mean. They're just unpleasant, bad people. They deviate from the norm in that way. But here again, we don't necessarily consider these people to have any sort of pathological conditions. And then finally, with mental illness, we usually associate these factors that don't necessarily accompany the other cases of deviant behaviors. So with mental illness, we usually recognize some sort of suffering. And some people conceptualize mental illness as some sort of psychological trauma. So it's not a dysfunction that is in the body. That's why we can't really observe it. But there is some sort of trauma somewhere in the mind of people. Then we also have the medical model, according to which every so-called mental or psychological dysfunction has some sort of organic cause. And then most recently, we have started to develop what's known as a biopsychosocial model of mental illness, where we recognize that all these three factors are intertwined in order to be able to conceptualize what goes on in people's lives. So there is an organic cause, that's the biological side of it. There's the psychological cause, that is, there's something, some unobservable trauma, some psychological trauma in the person, but also the way they function is conceptualized in a specific society. So different cultures, different societies are going to have different levels of tolerance to different behaviors. So what's going to be considered deviant behavior in one culture may not be a deviant behavior in another culture. So with these considerations, we're going to go over some possible explanations of deviant behavior that don't necessarily overlap with the medical model. So some deviant behaviors could be considered eccentricity. They may seem so radical, going away from the norm, that we're not going to consider these people completely okay. But at the same time, if somebody is exhibiting behaviors that are not in any way endangering anybody, we are going to be tolerant. So that's when we talk about eccentrics. We don't agree with what they're doing, but as long as they don't harm anybody else, then it's their thing. So they're simply eccentric. They're off from the center, eccentric. So that's one way to conceptualize different behaviors. Now, here is a way in which we also conceptualize some deviant behaviors. Some behaviors that nowadays would be considered having some sort of organic medical cause were traditionally considered simply moral failure, and many people still consider them to be such. And the two most prominent examples would be alcoholism and drug abuse. So to many people, it's a matter of choice whether you drink or not, whether you do drugs or not, and you know that's wrong when you do it excessively, and still you choose to do that. So you're simply being morally wrong. You are being a bad person. You're being immoral. And there's no recognition that there might be something going on in the person's brain that's actually producing these behaviors and dependencies, because we also know that not everybody becomes an alcoholic or a drug addict with a continuous use of alcohol or drugs. So just making that choice to drink doesn't make you an alcoholic. But again, traditionally, the point of view has been that people with drug addictions or alcohol addiction are simply morally flawed. They're choosing the wrong thing. Another way to conceptualize deviant behaviors when we say, well, somebody's just a bad person. There's a bad person, they are mean, they are violent, they are impossible to be around. That's just what they are. And that's it. We just are going to avoid them. We are going to walk on eggshells around them. But that's just how they are. So that's another way to explain deviant behavior. There's nothing that could be done. It's just the person is what they are, and there's nothing you can do about it. And then also, there's the notion that people simply choose alternative lifestyles, which may not be considered norm, but still they're choices. So to many people, being a homeless person, for example, is a matter of choice. And while it is possible that somebody does that, we know that a big majority of homeless people are actually people who suffer from one or another kind of mental illness. And then there's also the notion of deviant behavior, which is simply criminal behavior. But one issue with conceptualizing deviant behavior in criminal terms is that, again, there will be people who could be held responsible for their choices to do something wrong, but there are people who are out of control who just simply don't have the ways to make free choices. So in those cases, we are talking about mental illness. So the concept of mental illness comes with what we call the 4Ds. So deviant behavior by itself is not sufficient to qualify somebody as mentally ill. It is an aspect of the ill person's behavior, but if the person is perfectly comfortable with whatever eccentricities they have, then we're not going to talk about illness. But when deviance is also accompanied by distress, when somebody is really uncomfortable with the way they function, if they're always anxious, if they're afraid that somebody is going to stigmatize them or in some other way harm them, then we also talk about distress. Then we also talk about dysfunction. So a mental illness would incapacitate the person to some extent or other. We also talk about disability in this case. So the person doesn't have the capacity to take care of themselves. Many people with mental illness are not able to hold a job. They're not able to take care of their own hygiene. They're not able to perform daily tasks. They're not able to pay their bills. And many people lose their homes, and that's how they end up being homeless, for example. So this is where we talk about dysfunction. And finally, that's a big one, we also talk about danger. So mental illness poses a danger to the person who experiences it, in the sense of they become so dysfunctional that they may, in certain cases, be a danger to themselves. Many people with mental illness are suicidal, so that is an obvious immediate danger. And sometimes, this is not all that common, but people with mental illness may pose danger to others. And this is where they often get misidentified as criminals who should be held responsible. So when we identify somebody who presents with all of these aspects, we talk about mental illness, and in this case, people may be considered as not being responsible for their actions and not being subjects to punishment. This is where you can also have a plea for insanity if you are accused of some crime which happened in a crisis, in a mental crisis, where you weren't responsible for what you did. So these four are present in a person's life in order to be considered mentally ill. But from here on, there still are differences in the way somebody's condition could be conceptualized as illness. There is the point of view of psychoanalysis. Here, the idea is that mental illness is a result of some experience, some traumatic experience. There doesn't necessarily there isn't necessarily some sort of organic cause to the person suffering. So mental illness is going to be distinct from physical illness, for example. And the approach here to solving that problem then will be with some sort of mental intervention. And the very well familiar intervention that psychoanalysis does is when it analyzes a person's experiences, and once a person identifies that traumatic experience, then they will be free from it. They will be able to move on and be free from their trauma and be healed. But now that psychoanalysis has been around for over a century, we have already seen that very often this is not enough for somebody to feel better. Very often there is an actual organic cause that produces those behaviors and experiences that are distressing the patient. So this is where the medical model conceptualizes mental illness as having organic, physiological cause. Somewhere in the brain or somewhere else in the body where there is a dysfunction which affects the way the central nervous system functions, and that produces the deviant behavior. So under this conceptualization, mental illness can be treated very often with medication, but there also are other physical interventions that could be used in that case. So one of them would be transcranial magnetic stimulation. Another one would be deep brain stimulation. So these are going to be physiological interventions that aim at some change that will happen within the nervous system of the person, and that's going to result in the in handling of that deviant behavior. And this model has been criticized largely because not all medical interventions are successful, and very often somebody's treatment has to go through multiple trials and errors, and that process could be very disappointing. So it's very common that people would deny the effectiveness of psychopharmacology, for example, or other psychiatric interventions that aim at some sort of bodily function. So this is a big problem for people seeking help, seeking medical help, people adhering to a medical treatment plan that a psychiatrist has set up for them. So this could be a very problematic situation. But medical psychiatry has made a lot of progress, and there have been multiple improvements on psychopharmacological interventions, that the medical model is becoming more and more refined and more successful, and proves itself better than some of these traditional approaches to deviant behavior in explaining what goes on with a person, and also intervening and changing the behavior and alleviating the suffering and getting people back to normal functioning. But something to consider, and we mentioned it before, is that the impairment of a person, that's one of those 4Ds, the dysfunction, may be contextually defined. So somebody with some level of alcohol consumption, for example, could be considered perfectly fine in certain cultures. In Europe, for example, it's very common that people have a glass of wine or beer for lunch, a glass of wine or beer for dinner every day. And it's not uncommon that people would have that glass of wine for lunch in their lunch break. So they would go back to work, and that would be perfectly fine. Of course, not all professions would allow for that, but for example, academics, intellectual professions allow that. If you don't operate machinery or any sort of occupation like that, it's not going to be considered in any way impairing. But in many cultures, any consumption of alcohol more than once or twice a week would be considered disabling. For example, in the US, having alcohol every day, more than one or two drinks, would be considered pathological. So that's something to keep in mind. In different social contexts, something could be considered disability, but not in others. So part of the definition of mental illness then would become the social aspect to it. How functional is the person in their specific surroundings? If they're functioning just fine, even with some sort of disability, they would be considered okay. So with that recognition, the biopsychosocial model becomes more and more prominent these days. So here there's a realization that mental illness is a very complex phenomenon. It has all of these aspects. It has an organic biological cause. In the case of, say, drug addiction or alcoholism, some people simply have that kind of brain chemistry that makes them more easily susceptible to addiction. And that, coupled with the social context in which these people are situated, if they're surrounded by people who drink every day, that's going to become part of the causes of their condition. And then also there will be the aspect which is simply the history of the person's experiences. So we know that people tend to want to drink when they're in some disturbed state or other. And if that kind of emotional state is coupled with that social environment where alcohol is readily available, and also with the person's predisposition to addiction, here we have that complex structure of causes that are intertwined and lead to alcohol addiction, for example. So in this case, the treatment from the biopsychosocial model of mental illness then would recommend medication or some other medical intervention to handle the biological cause. Then it will also recommend typically cognitive behavioral therapy, though other talk therapies may be also recommended. But the approach to talk therapy that has proven most successful so far is cognitive behavioral therapy, where the person is made aware of their behaviors and learn to recognize the ones that are in some way damaging and avoid them. And then there's also the recognition, again, that the person's illness being situated in a context, there are interventions that aim at the immediate surroundings of the person and their family. So the whole family will also be invited to participate in a setting where they all will be made aware of what triggers the person's vulnerabilities and how they can handle it, or if the person has episodes in which are very irritable and are difficult to communicate with, when the family is educated on these aspects, they figure out ways to handle that situation. Also, the families of mentally ill people struggle themselves. Many people develop some mental illness or other, typically depression or anxiety, simply because they are exposed to the behaviors of the person who is the original mentally ill patient, the mentally ill member of the family. So that's an intervention that's also very important. And also making sure that there are good social services and people could be accommodated, like we do at UT, for example. If somebody has some sort of psychological disability, they would be accommodated, whether they would be given more time on their tests, whether they would be given alternative test locations that are less distracting. That would be an accommodation that we would make. People with hearing or vision impairments are also entitled to accommodations at UT, and we do all of that with that recognition that people's disabilities are disabilities in context. So if the society does something, that's going to alleviate some of the dysfunction that people are experiencing. And in the case of mental illness, that there are interventions, again, that we as a society can make in order to alleviate the people's suffering. So that would be helping them with their condition in those more indirect ways. So that's also now considered a part of the intervention that alleviates mental illness. Now, finally, let's consider treatment approaches. So we looked at all of these interventions that are very successful. Biopsychosocial model has been really successful. Those complex interventions help people recover and find their ways to function successful in society. But those would work when people choose their treatment, when the treatment is voluntary. Unfortunately, a lot of mental illnesses come with this additional complication where people don't have an insight onto their condition. They don't realize that they're suffering from some illness. They don't realize that they have a dysfunction sometimes, but sometimes even if they do, they still refuse to, or simply don't have the insight that this is a treatable condition and whatever treatment is offered to them is actually going to help them. One part of it is that not all treatment is successful right away, and psychiatric treatment often has to go through multiple trials and errors. So that could be very discouraging. So even if somebody recognizes that they have a treatable condition, but their treatment hasn't been successful so far, they may still refuse treatment. Another issue is that very often when people are treated with some medical interventions for their psychiatric conditions and they start to feel better, they consider themselves to be already healed, recovered, and quit their treatment plan and then refuse to accept that they're slipping back into their illness. So there are all of these complications with mental illness. So it is the illness itself that incapacitates the person and puts them in a position that they simply cannot provide consent for treatment because they don't have that insight, what's happening with them. But also with that lack of this capacity comes the lack of the capacity to also have your full autonomy. So remember, when we talk about free choices, we talk about somebody who's capable of seeing the consequences of their actions and being responsible for the consequences of the actions they perform. So this is where we talk about autonomy. People are autonomous when they can make those decisions based on all the information that's given to them and their desires. But here, the issue is that people simply do not have that capacity to be autonomous, whether because they're lacking insight or whether because they simply are not in a position to recognize what's good for them or not. And under these circumstances, they may need to be involuntarily treated. And that typically is considered to be morally justified when they are a danger to themselves or others. So that's the minimum that that is considered to be a threshold that when it's crossed, the medical community would have the moral the moral justification to treat somebody involuntarily, which may be violent and in certain situations when the person is resisting admission to a psychiatric clinic, when the person is resisting treatment, and they may become violent, not necessarily because they are aggressive, but because they're trying to protect themselves from perceived danger when somebody is trying to force some treatment onto them, that the situation could escalate, and the medical personnel together with security may actually have to restrain somebody, and that is going to go through some violence. So, considering that, there is a very difficult moral choice to be made, whether we have to prioritize the person's autonomy. Should we just let them be? Should we just let them refuse treatment? Because remember, that's one of the rights that we consider to have. Should we let them make that choice? But knowing that making that choice is going to harm them too much, isn't it better to overrule their autonomy in this case, but make sure that they're well, make sure that they get the benefit of the medical care that they need? So it's a difficult conflict. And then again, here is the relationship between the minimum morality that we want to uphold and what we expect from the government to do in order to make sure that people's moral standards are in fact covered. And this is why many governments, many Western governments, do allow for involuntary treatment of mentally ill people when they pose danger to themselves or others. Now remember that in many cases, unrecognized mental illness may in fact result in violence, and in many of those cases, when there isn't that recognition, people get incarcerated. So, in a sense, they get punished for a medical condition that is treatable and they cannot control. So here again, making that judgment whether to restrain the person in a psychiatric clinic where they can be treated and get well, or treat them as if they're making those choices freely, but then having them break laws and be incarcerated and be punished for that. Which one is the lesser evil? So in this case, the cost-benefit analysis is going to become important. So here again, beneficence is going to weigh very heavily against autonomy. So I'll leave you with that thought, and I hope that what we've been doing here is going to provide some insight for you, and you will be able to see where you stand in this conflict, specifically between autonomy and beneficence, and see for yourselves what you might recommend somebody to do in that case, or what you would do in the event that decision came for you to make.